Yes, absolutely. It's great to be here. Thank you so much for the opportunity to give this presentation. We were so excited that I have a studio and we recorded the vitamin D lecture. So I'm just going to share my screen. If anybody has questions, I'm more than happy to answer them, and I'll probably do so throughout the lecture. And I already see that some people are from Venice, Florida, where my parents live. So it's a great opportunity to be here, and I'm very excited to share this knowledge. We also have a couple of polls. So throughout, you're going to see some polls that are going to pop up. And I hope you guys answer the polls so we can figure out, what kind of audience we have here.
I won a scholarship and I moved to Switzerland. And I went to Switzerland because it's really a headquarters for implant dentistry. A lot of research is done there. And I spent 7 years from 2009 to 2016 on and off doing a lot of research there in the field of implant dentistry. I'm a trained molecular and cell biologist, so I spend a lot of my time in preclinical research. And of course, I do a lot of collaborative work with a lot of the experts that are at the University of Bern. For those that are unfamiliar with Bern, of course, it's the #1 rated dental school for citations per paper. So it's very well known for all of the research that's been done over the years. A lot of credit goes to my supervisors who've really provided this great opportunity to do research and continue to do research in this field. Tony Scullion here is one of the most well-known periodontists in the world. He does a lot of work with growth factors, specifically with emdogain and a lot of surgical approaches. And of course, Dr. Boozer was my other supervisor, did a lot of work in the GBR field, a lot of work in the implant field. And the advantage of working in Bern for myself, as well as my colleague who helped edit the textbook, Yufeng Zhang, was that we got a lot of biomaterials. We could do a lot of testing of biomaterials, growth factors, etc. We can do a lot of the preclinical work and then send them to the clinicians, the expert clinicians who would then be able to utilize these different biomaterials in clinical practice. All of the work that was done has been tested in clinical applications. So everything we do in the labs is really, we're going to take this course from preclinical work all the way up to where we are today, where we can use them in clinical practice. I also wanted to give a lot of credit to other preclinical researchers that have had a huge impact on my career. So of course, while I was doing a lot of the cell biology work, Reinhard Gruber was head of the cell biology department before I got there. We did a lot of work together, and he's really a master in cell biology. He's located currently in Vienna, as well as Dieter Bossart, who's one of the top histologists of the world. And he's really done a lot of work side by side with us. While we do cell bio stuff, he does histology and animal models, and it's been a really great collaboration between these different individuals. Now, I currently live in Florida, so I relocated in 2016 to Nova Southeastern University. This is where we did a lot of research related to things to get biomaterials approved by the FDA. A lot of work was done here with respect to platelet-rich fibrin, as well as more work on osteogain, as well as BMPs, etc. So I'm currently located in Florida. Like I said, it's a fun place to live, and I'll talk more about my collaborations that I've established since moving to Florida. And this is the building right now. So this is the Center for Collaborative Research, where we did a lot of work on platelet-rich fibrin and big facilities. And these facilities are basically dedicated to doing preclinical work. So a lot of these labs, like I said, are very expensive. They're equipped with very expensive materials. And the goal of a preclinical researcher is, of course, to take new materials, improve them, develop them, and then bring them through the FDA. So of course, for that, we need to do a lot of basic research studies in facilities such as this one, as well as we need to do a lot of animal research prior to using them in clinics, so doing clinical studies. The book itself is a big textbook, so you can see here it's about 400 pages, and it covers all biomaterials. So again, bone, periodontal regeneration, that's really the focus of the course here. And we're going to talk step by step through every single chapter and go through it. For those that don't know, Quintessence has a list of the top books of the year, and earlier in 2019 it was ranked #1 in the world, so it was actually the most sold book. And one of the reasons why is because it fills this big void where a lot of clinicians are unsure which biomaterials they should be using for which indications. And so people don't even know simple things like where should I use allografts versus xenografts? You know, what are some of the BMPs? How do we use them? How do we use Emdogain correctly? And there's never been a real book focused on biomaterials. And so I was actually thrilled. I remember getting the phone call from Quintessence that, you know, one day they called Yufeng and I and just said, you know, your book is the most sold book in the whole world. And I think it's really a reason for that is because clinicians are not getting the material that they need, the info that they need on biomaterials. A lot of that info comes from sales reps. And of course, I always say, you know, you want to practice dentistry as evidence-based as possible. And so this book really fills that need. I have to give a lot of thank you to Quintessence, of course. So this is a lot of this course is thanks to their work in putting the book together. So of course, I want to acknowledge them, as well as all of the clinicians. So this is just a huge list of different people that contributed. There was more than 70 co-authors. They're coming from all over the world. I'm sure if you're listening to this course, of course, you know, you recognize some of the names on this list. And a big thank you to all the people that helped contribute and write the textbook. Especially, I want to thank these two people. So Tony Schoolian, of course, is more the perio side. He contributed 8 or 9 chapters, as well as Mike Picos on the bone biology side. So these guys have really established a big reputation in their respective fields. While we were doing a lot of the work, the nice thing is that, you know, we're taking these biomaterials from preclinical to clinics, and these two people in particular were really helpful in establishing, you know, real clinical guidelines for a lot of these biomaterials. And I thank both these people and mentors tremendously for their impact on my career. Okay, the book. What we tried to do in the book, which was very different, was we said, what is the standard biomaterial today? So these are things like autografts, allografts, xenografts, etc. And what are future materials? What are the next generation biomaterials? So here's a list of commonly utilized biomaterials today. And then here's a list of future, we call them next gen biomaterials. So on the chapters, you'll often see, you know, a title. If the title has next gen biomaterial, it means it's kind of a future biomaterial. It's one that's currently in the labs or just recently released, and one that's going into clinical practice very, very shortly. We call those next-gen materials. And these are things like, you know, 3D printed bone grafts, dentin grinding, tetranite, the adhesive grafts, more to do with platelet-rich fibrin, atelocollagen membranes, and certain new growth factors. You can see here, and I always say this, growth factors is really the future of medicine. That's where a lot of people are doing more and more research. So when you see things like osteogain, BMPs, hyaluronic acid, this is all things that are, you know, slowly getting to market and becoming more and more widely adapted in clinical practice. I also want to give note that the textbook itself, I dedicated the book to one of my first supervisors. So it was somebody that I trained with in North Bay, Ontario. And unfortunately, he passed away from a heart attack at the age of 65. And he was the first person that I learned science from. And so all the proceeds from the book and the dedication go to him. So there was a scholarship that was created in his name, and you'll see here 100% of all the royalties from the book itself go to this person. Like I said, I had a big blessing because as I grew up, I did a lot of these high school science fair projects. And every year I go back to North Bay and present a scholarship from the royalties in his honor. Okay, so in this module, we're going to talk about biomaterials and the body, okay? It's very, very important to understand that when you have a new biomaterial and you're going to place it in somebody's body for the first time, it's very important that it doesn't cause a foreign body reaction. It's very important that this biomaterial is not going to cause additional inflammation. It's got to be a safe material. And a lot of people don't understand that the first cell type that comes in contact with biomaterials is always going to be immune cells, okay? So if I have a new implant or if I have a new bone graft, it's very important to understand that when this implant goes into a human body, okay, it's not a happy medium where bone is being formed and osteoblasts come in, etc. Its implant is inserted in the body, immune cells come in contact with the implant first. Immune cells decide whether or not they like this material or not. Immune cells decide whether or not they're going to reject the material or not, okay? And so it's very important that these immune cells are in perfect health and that the immune cells like the biomaterial that's being implanted, Okay, I can't stress this enough because a lot of people forget this, is that your immune system is really dictating, the fate of every biomaterial that's ever going to be placed in the body. It's really the immune system that's responsible for that. And here you see Donald Brunette. And Donald Brunette is well known for his research that he did with implants. And more specifically, he showed that for one of the first times, bone formation on implants is preceded by macrophage accumulation. Okay, so it's been known for more than 10 years. When these implants go into the body, it's not bone that's coming in contact with the implant. It's always immune cells first and macrophages, and they decide whether or not they like the material or not. And he's won many awards. Like I said, he's been well recognized by the IADR for winning a lot of these Distinguished Scientist Awards. Now, when we talk about macrophages and immune cells, we call them plastic cells. And this means that they can become very inflammatory or they can become very happy. So if a macrophage, for instance, is very inflammatory, and you can see here on the slide, dark side, it's called an M1 macrophage. And if this immune cell is very happy, we call them an M2, and they typically have immune suppression as well as tissue repair. Okay? Ideally, we want our immune cells to be more M2, where they're going to be more pro-resolution, and they're going to build bone or build tissues. But when they're unhappy and they're M1, that means that they're very inflammatory and they're secreting a lot of interleukins, TNF-alpha, etc. Okay, so that's just the basic knowledge for macrophages. Macrophages, of course, are the first cell types that are going to come in contact with biomaterials. They're very critical during bone remodeling. And one of the studies that was very interesting, and this was done in studies in Australia, when you have bone and you want to make bone, if you have bone cells, which are osteoblasts, and you have them making bone, okay, a group of researchers found that if macrophages, the immune system, is not present, there's a 23-fold reduction in mineralization potential. And that's absolutely huge, okay? When we talk about things like PRF, you might get a 60% increase in bone. When we talk about things like BMP2, you might get a 6-fold increase in BMPs, in bone formation. When we talk about immune cells, it's 23-fold, so it's massive. And the moral of some of these early studies that were done more than 10 years ago was immune cells really dictate, bone formation. Okay, so you need to keep these immune cells extremely happy. And fast forward, about a decade, now we've learned that these macrophages are very plastic. And what that means is that a macrophage, which is M1, so he's unhappy, he can become happy again very quickly. So there's different markers that you can make them, M1, M2. And this shift can occur between day 8 and day 11. So within about a 3-day period, you can have a very unhappy macrophage and he can become happy. Or the opposite can happen. You can have a happy macrophage, M2, and he can become unhappy within 3 days. And all this means is that, and that's why we call them very plastic cells, they can go back and forth between happy and upset within a 2 to 3 day period. Okay, and it's very important that when we talk about biomaterials, when we talk about peri-implantitis, periodontal disease, as much as possible, we want to try and regulate these immune cells to be more on the M2 side so that they can help regenerate tissues, mainly because they're very important for bone formation. When we look at implant studies, Dieter Bossart's been one of the leading histologists of the world, and he's done a lot of work with titanium, titanium, zirconia, all different implant systems over the years. He's got more than 200 publications, and really looking at how immune system integrates with biomaterials, how they make multinucleated giant cells, etc. And we wrote an article in 2016 together, and it was titled OsteoMax, Key Players Around Bone Biomaterials. And that stands for osteal macrophages. So the whole point of this article, and it was more on the basic research side, was these osteomax, or these macrophages living in bone, are basically some of the most important cell types found around bone biomaterials. And that led to a huge amount of studies thereafter on this topic. You've seen more recently, of course, with Albrechtson's group and Weinenberg, they've talked a lot about the immune system and how it impacts peri-implantitis. So here you see these foreign body giant cells and how they impact bone loss, peri-implantitis, etc. And as well, this new concept. Now we see a lot more articles talking about titanium particle release. And so in the Journal of Dental Research in 2018, you've seen studies now is metal particle release associated with peri-implant bone destruction an emerging concept? And have a look at the authors. Here we have Toby Fretzworth, who's one of my colleagues that I work with. Kathia Nelson is supervisor. We've had Dennis Tarnow, who's very well known in the implant field. Homley Wang, William Ginobili in Michigan, very well-respected colleagues. And they're talking about titanium particle release as being an emerging concept. And when you read the conclusions from these studies, you see, metal particle release as a potential etiologic factor has been intensively studied in the field of orthopedics and is known to provoke aseptic loosening around, orthopedic implants. In dental medicine, emerging information about metal titanium particle release suggests that the potential impact of biomaterials at the abutment or bone interfaces may have an influence on pathogenesis of peri-implant bone loss. Okay? This article is a great article for anybody that wants to read more about peri-implantitis and titanium particle release, because it's written by some of the key guys in periodontology, and really it's becoming an emerging concept. An article that's really interesting as well is, for those that are more in the implant field, is looking at osseointegration of titanium versus titanium alloys and zirconia. And of course, this was written by Dr. Bossart, Vivian Chapuis, and Daniel Boozer. And it talks a lot more about zirconia implants, talks a lot more about titanium particle release / zirconia not having this potential issue. This group right here has done a lot of work in that field, of course, and highly encourage people to read this publication. And for those that want to learn more on zirconia implants in particular and using more of a holistic approach, of course, Dr. Bossart's one of the key guys in that field, and he comes to North America once per year to give a course with us. It's called Going Green. And for those that want more info on this course, it's located at purefedu.com/going green. And you can learn more about implants, titanium, how they integrate. And I teach a little bit about platelet-rich fibrin in the course, as well as dentin grinding. Very good course for those that want to learn more about going a little bit more holistic in implant dentistry. Now, when we talk about the immune system and we talk about gum disease in particular, it's very important to understand that today it's very well recognized that with gum disease, it's linked to very many systemic issues. So now if you go to perio.org or some of these websites, we see very commonly that periodontal disease is linked to respiratory disease, to heart disease, to Alzheimer's, to diabetes, to arthritis. There's many, many links with perio and systemic disease. And if you think about this, if you were a dentist 30 years ago and you said, if you get periodontal disease, you might have a higher chance of strokes and heart disease, you might be considered far out there. But today, these links are very, very well characterized. In fact, today people ask the question, is it perio disease that's causing diabetes? Is it diabetes that's causing periodontal disease? And really, both of them are causing inflammation, right? Both of them are causing systemic inflammation, and both of them contribute to one another. Okay, so it's very important to understand that essentially what's going on here is that you're increasing overall inflammation, and whether or not you have perio disease, it's going to cause all of these disease. And if you have diabetes, it's also going to be linked with a lot of these diseases as well. A lot of this has to do with, it's well recognized now, but a lot of this has to do with your immune system now being dysregulated, okay? And if you talk about this from a biological point of view in your body, essentially what's happening is that M1, M2 macrophages, this shift of whether it's M1, M2 is being dysregulated. Okay, now instead of having more of these happy macrophages and having more M2 macrophages, we have more M1 inflammatory macrophages. And so whether or not that inflammation starts from your mouth, from periodontal disease, now it's getting transferred to other parts of the body. You now have more interleukin secretion, you have more TNF-alpha, it's circulating in your body, your immune system's now dysregulated, and now you have a chance of having all of these different issues related to this dysregulation. I give a lot of credit to these two researchers here. They've done a lot of great work. They're located in Boston. They do a lot of work with Harvard, as well as the Forsyth Institute. And they're really looking at immune cell health and how it relates to periodontal disease. And one thing that's very interesting is that they've characterized resolvin. And these resolvins were developed at Harvard as a result of inflammation. So they were trying to figure out a way you have inflammation in your body, let's try and decrease inflammation. How do we do that? We use molecules that are called resolvins, and they did a lot of work in that field. They also did a lot of work in resolving, using resolvins for reducing or improving bone formation, okay? Decreasing inflammation, improving bone formation. And I want to share with you guys one study that I find very, very interesting. So this study right here is called Resolving Macrophages Counter Osteolysis by Anabolic Actions on Bone Cells. And was published again in the Journal of Dental Research, very good article here, very good journal. And essentially the way that they've done this study is that they looked at perio, so an animal model where they actually take ligatures, they wrap them around the teeth, and when they do that, of course, you have bone loss. So you start to see bone loss here, and then the whole goal is to try and regenerate this tissue. So you can remove the ligatures, you can use different molecules, and you can regenerate these tissues here. And so in this study, like I said, they place these ligatures, and you start to have bone loss. And what you're trying to do at day 21 here is you remove the ligatures and you start to regrow this bone using different molecules. And so in this study, they used two different types of drugs. The first one was to eliminate macrophages completely, and the second one was to induce more of these happy macrophages, so more of these M2 macrophages. And the drugs were carefully selected as a result of trying to show, the reader what the effect of immune cells are on bone formation, so periodontal regeneration and loss. Okay, so when we look at these two drugs here, if we place the ligature in a control animal, they're obviously going to lose a lot of bone. So you see here in the control, you lost a lot of bone. You can see that the roots are now being exposed. If you use a drug that's going to eliminate macrophages here, you notice that you don't actually lose that much bone. Okay, so if you could eliminate macrophages completely, you could maintain your bone. And if you made these macrophages happy, so you went more towards the M2 macrophages, you still lost some bone, but not as much as in the control group, okay? So the moral of the story is if these macrophages are happy, you're going to maintain more bone. But if you can just completely wipe out these macrophages, you're not going to lose very much bone, okay? And it tells us that the immune system and these macrophages are really dictating whether or not there's going to be bone loss in this model here. And then they did the opposite. They said, well, what if we use the same two drugs for bone formation? Okay? So if we remove the ligatures now, we're going to see that we're going to start to regrow some bone, and that's what we see in the control sites here. Now, in the actual ones where we eliminate macrophages, we don't see any bone formation, and that was very, very interesting. Okay, so we're not seeing bone formation when we eliminate these macrophages. When we make them happy macrophages, so we make them M2 macrophages with this drug, then we have a lot of bone formation. Okay, that's where we get the most bone formation. So again, conclusion from this set of experiments was if you eliminate macrophages, you don't have bone loss in the first experiment, and if you eliminate macrophages, you don't have bone formation either. And what does it tell you in the conclusion of the study is that these macrophages control bone loss, and they also control bone formation. And so now the strategy based on these studies that were published in JDR is if you can control macrophages, you can really make bone and lose bone, and making them happy will make more bone. And so instead of having the strategy where we try and use growth factors, necessarily such as endogain to try and regenerate bone, maybe the strategy should be to try and modulate immune cells. And when you can modulate them and make them happy, that's when you can get, regeneration. And, while we were reading a lot of these articles, I wrote this article with several colleagues that were in Michigan while I was there, and we worked with two youngsters that were very prolific in research, in fact, both Angel and Alberto here, as well as a senior author, Professor Homley Wang. And in this study, it was called Basis of Bone Metabolisms Around Dental Implants During Osseointegration and Peri-implant Bone Loss. And what was interesting is that in this study, we were trying to characterize, what happens and what is the reason for bone loss around these implants. And we talked about, low vitamin D intake. We talked about immune cells as being key regulators in dental implant osseointegration, and how these cells are crucial for biofilm accumulation and their association with basically hard and soft tissue breakdown. Okay. Very amazingly, like I said, I got an email one day and it said, "Congratulations, dear Richard Myron. We're pleased to announce that your article, this one here, was one of the Journal's top 20 most downloaded in recent publication history. And this was from between July 2016 and June 2018. And I remember reading this and thinking to myself, wow, out of all the research that we're doing and all the cool research we're doing on tetranite, on BMPs, on emdogain to osteogain, on platelet-rich fibrin, etc., this was the article that was most downloaded. And the reason why I find it interesting is because it really showed that people are really, and dentists are really paying attention to how important these immune cells are around biomaterials, okay? And especially the topic of vitamin D, which I'm going to go into more detail here, became a really hot topic, so to speak, in dentistry. And so we know vitamin D, of course, is one of the vitamins for bone, okay? It's no surprises here, if you're an osteoporotic lady and you start to have osteoporosis, the first thing that a medical doctor is going to recommend to you is take vitamin D and vitamin K, right? And that's going to be one of the first, let's say, drugs or vitamins that's going to be prescribed to you. And vitamin D has a very big role in immune cell health, okay? And more recently, there's a lot of links between vitamin D and diabetes, heart disease, high blood pressure, multiple sclerosis, etc. Okay, so these links are being very, very well established as well. And when you look on vitamin D deficiency, you see a lot of links with depression, with asthma, with Alzheimer's disease, with cardiovascular disease, with diabetes, with hypertension. And when you look at this list, it looks very, very similar to periodontal disease. And basically, whether or not you have diabetes, or you have periodontal disease, or you have vitamin D deficiency, every single one of these is linked to immune cell health, which is now being dysregulated. The immune system's now repressed, and things are not working as properly. And vitamin D is a contributor to every single one of these. And for general health purposes, like I said, probably vitamin D is one of the vitamins that you should have at optimal levels at all times to make sure that you're not one of these people that are more susceptible to cancer or Alzheimer's, etc., as a result of being vitamin D deficient. In the dental field, more than 10 years ago, vitamin D was associated with implant osseointegration. So here in this study, in this animal model, they found that if these animals were vitamin D deficient, they had a 66% reduction in implant pullout strength. Okay, and what this meant was that if this was bone and this was implant, they place the implants and they do these pullout tests. They basically try and yank these implants out. And the animals that are vitamin D deficient have typically a 66% reduction in their strength. Okay, so they have a lot less strength. They're not as well integrated, and therefore they can be removed much more easily. And it was Reinhard Gruber. So again, he was the head of oral cell biology in Bern. He associated this negative impact as well. So he established that in an overoptimized rat model. But he also found that if you gave supplements, you can improve the integration. So one of the things that he found in 2012 was that, of course, vitamin D deficiency is associated with lower bone implant contact in these implants. But more importantly, it could be compensated with supplementation. Okay, so you could actually give these animals vitamin D as a supplement, and then the implants would then integrate properly again. Of course, then some years after, there started to be some case reports, so in humans. In this study here, vitamin D deficiency associated with as a suspected factor in early implant failure in these immediate implants. So these were some case reports. There was another study in 2014 that showed that two neglected biological risk factors in bone grafting and implantology, high LDL as well as low serum vitamin D levels. And as well, Toby, so somebody that I worked with closely in Michigan, showed as well vitamin D deficiency in early implant failures, two case reports. And this was back in 2016. And, long story short, working in academics and working at universities, we're always trying to figure things out to try and help the population. And these types of cases, I remember discussing with him, these are the types of cases that you have an implant, you place an implant in a lot of bone. So you got adequate bone, you got bone bleeding, everything looks healthy. Implant goes in, implant's osseointegrated, and then 4 to 6 weeks later, it turns out that the implant is not integrated and it's a spinner and it's coming out of the mouth and you're scratching your head asking yourself, why did this implant fail? And so as researchers, we take these patients and we send them for analysis. So are you allergic to implants? Are you allergic to titanium? Is there a sensitivity? What is the reason for this? And when we send them across the street to the medical school, they always came back with deficiencies in something related to their immune system. And most of the time, like I said, it was associated with vitamin D deficiency. So in these cases here, it's typically patients that are critically deficient in vitamin D, and that's one of the reasons for these early implant failures. Now, this study here, which was done by Professor Mangano in Italy and some of his colleagues, was one of the best studies on this topic. And the reason why is because it was one of the first times that they've looked at thousands of implants. It was close to 2,000 implants here, placed in nearly 1,000 patients, and looking at the association. So overall, it was found that about 4% of these implants fail, which is normal. In heavy smokers, you see an increase, by about 50% to 6%. So heavy smokers defined by 15 cigarettes or more per day have 6% failure rates. Same thing with generalized perio, 6% increases here. Now look at what it is in vitamin D deficient. It's 11%. And that's almost from 4% to 11%. That's almost a 300% increase in failure rates. And what was amazing about this study was actually vitamin D deficiency was a higher risk factor for early implant failure when compared to smoking 15 cigarettes per day or having generalized perio. And that's something that, at the time was kind of suspected, but not, scientifically necessarily proven. But I always, talk about all the colleagues that if you're a smoker and a heavy smoker, you'll definitely have somebody sign an informed consent. But if you're vitamin D deficient, do you have these patients sign informed consents as well? And if you're not, you probably should be, because of course the link is higher there than it is for smoking. And fast forward several years, now we've learned that this is a very easy problem to fix. If somebody's vitamin D deficient, then you can supplement them and they get up to the right levels. It's very easy to do. But if they're smoking 15 cigarettes per day, it's very hard to have them quit smoking. And more recently, like I said, with everything going on today with COVID, or in the past, if you watch this video in a year from now, one of the things that was very, very well instructed to general society was that, the CDC launched all of this news where if you're vitamin D deficient, of course, you're less likely to be able to, fight against COVID or different types of diseases, right? Vitamin D is very important for overall health. And if you're low, and if you don't know if you're low or not, I highly recommend getting tested, because having optimal levels of vitamin D will help you against pathogens, etc., but also will help you against implant failures as well as bone grafting failures. Now, when we talk about the general supplementation guidelines, it's very important to read some of the endocrine publications. So this is a paper that was published by medical doctors. They're all endocrinologists. And they give recommendations on supplementation. So when we look at this in the Endocrine Society of US, if you're deficient, it's considered anything below 30 nanograms per ml. So that's number one. You want to be above 30. Ideally, you want to be between 40 and 60. So this group of experts, like I said, their recommended range of between 40 and 60. Adults on a daily basis should take between 1,500 and 2,000 units per day. And if you're a doctor, dentist, and you're spending all your days indoors, this is highly recommended, because of course you get your vitamin D from sunlight, and most of us are not spending enough time in the sun, and that's why supplementation is typically recommended here. Now, interestingly as well is that if you're obese, you typically require as much as 3 times more to maintain these levels. So the absorption goes down. It is a fat-soluble vitamin. And so in obese people, like I said, you typically need a little bit more to get your levels up to proper standards. When you're deficient, this group typically recommends 5,000 units per day for 12 weeks. So if you're deficient in vitamin D and you go to the doctor will typically recommend that you take these little vitamins for 12 weeks, 5,000 units per day. And I remember looking at this and saying, is there any way that we can get this shortened? Because 12 weeks, first of all, is a long time. And if an implant needs to go in, waiting 12 weeks is really a long time to wait before these implants actually get inserted into the body. And I'll speak about the research that we've done with Denimedica to shorten this down to 4 weeks. Now, many people are not aware, but you can do vitamin D testing in office. It's very easy to do, and it's done with a simple little finger prick. Okay, and I'm going to show a little video of how this is done. There's many different devices that are available. In Europe, you can get this from Biotech Dental. In North America, you can get this from Dentamedica. And this is a very simple test to do. Like you can measure glucose from a single drop of blood, you can do the same thing and measure vitamin D levels from a simple drop of blood here. So again, with this very small sample, 10 microliters, you can take a drop of blood, you put it into this little reader, and within 10 to 15 minutes, you get an answer, okay? So I'm going to show you how this test works. I got a little video here. So in this video, and I'm going to thank Dr. Paz who provided this video, you're going to see how this test works. So again, first thing we're going to do very simply, and this doesn't necessarily have to be done by a dentist, of course. You can get one of your assistants or somebody in office to do this. You take a finger prick, right? So you're going to use some device, and of course many of these exist. You're going to poke a little bit of blood here. Now it's very recommended that you try and squeeze out more blood than you probably need. And the reason why I say this, and I purposely show this in this video here, is that you have to get 10 microliters of blood, and on these little collection devices, there's a little line here. You don't see it on the video here, but you got to get it a little bit higher. And if you don't have enough blood there, you have to, squeeze a little bit more. So it's always better squeeze enough to get, 10 microliters, or let's say double what you actually need. And then it makes your job a little bit easier. The more you use this device, of course, the more comfortable you're going to feel with it. Then the devices typically mix with a buffer. And the buffer then has the antibodies for vitamin D. And that's what's going to allow the reading to occur. So in this case here, we're going to place a few drops. And then we're going to take the blood and we're going to place it in there. And we're basically just going to mix these two together. So you're just going to shake very carefully here and make sure that it's well mixed. Okay. Once that's done, then we can take the blood sample and place it in the sample reader here. So then we're going to place it in the sample reader. And once that's done, you're going to see now that the blood is going to, it's basically a titration unit where the blood is going to come up this test strip. So in a few seconds here, you're going to see the blood is going to start coming up. And you see two lines there, the control line and the test line. So the control line is there just to make sure that the test is actually working. So now you can see the blood is starting to come up, okay? And now it's going fully up. And you start to see the control band showing up. So now you can see the control band. Okay, so that's just to confirm that it's actually working. And then the way that the test works is that there's a little cube reader, and this reader can be utilized to measure many different types of vitamins or other testing strips. So you have to basically program it to measure vitamin D. So each one of these, it gets programmed. And we do that with a card. So it's very easy to do. You take the RF card and you basically just swipe it over top of it. When that's done, it beeps at you, and then you hit the little test button, and then the test is now started. Okay, so very easy to do. In Europe, the test typically is 15 minutes. Okay, in North America, a company in Canada was able to bring this down to 10 minutes, and you can get that one there at dentamedica.us, and that's available in North America. So the timer comes on, 15 minutes in this case here. As the time is counting down, okay, you can sit there. Ideally, you don't want to move this thing, and then the reading comes. So in this case here, it's 50.2 nanograms per ml. So for this patient, which is obviously one of our staff members, this video was provided by Dr. Anna Paz, who works at the White Clinic, is between the 40 to 60 range. So of course, she knows how important vitamin D is, and testing was done, and she's within the right ranges. So apart from vitamin D, another thing that's very important as well is antioxidants. Okay, and very simply put, anytime that you have stress applied to your cells or your body, so that can be from radiation, that can be from alcohol use, smoking, etc. Always remember that if this is your nucleus in your cell, and this is oxidative stress, your oxidant, it's basically wanting to go and hit the nucleus and cause DNA damage and mutations, and that's what causes cancer, etc. So if this is a UV light's coming in, causing damage to your cell, and you want to protect yourself. And the way you protect yourself is antioxidants. And the antioxidant, basically it's antioxidant, it protects you against oxidative stress. The more antioxidants you have, the less chance that this oxidant can affect the nucleus. So antioxidants are very, very important, and very important during surgery because you're going to go through a stressful event when you go through surgery. Now, I was amazed to learn that, of course, the supplement business in general is obviously huge. So I remember going to the headquarters of some of these different supplement companies because I was talking about vitamin D and talking about how important it was for implants to integrate to have adequate levels. So I wanted to not do the 12-week recommended period by Endocrine Society. I said, look, is there any way that we can, cut this down to, half that or a third that to 4 weeks? And so I collaborated a lot with these nutritionists and endocrinologists and these PhDs in nutrition. Great group of people, highly dedicated to trying to optimize, of course, supplementation, making sure that patients were at adequate levels before they go into surgery. And amazingly, like I said, when I started reading more about this topic, a lot of great research on this topic. Pat Allen here has done a lot of work in this field using antioxidants for periodontal disease. Okay, so they found that in general, antioxidants are available through oral ingestion, of course, diet and vitamins. And this review talked about the relationship between antioxidants and free radicals, so ROS species in the oral environment. Okay, very, very important for periodontal disease. And somebody that I give a lot of credit to as well is Ian Chappell, and he's located in UK. And of course, in London, UK, there's not as much sunlight, right? And so as a result, people are more vitamin D deficient, like they are in Canada as well. And in these cases here, they recommended for preventing periodontitis, daily nutrition should include sufficient antioxidants, vitamin D, and calcium. And if you have inadequate levels, you might lead into problems. And so these studies really talk about the biology of that. And, I was very surprised to learn about a product that was called Vitamedica. And this was based out of California. And the way that I learned about it was actually, I was doing a lot of PRF research. And so I was teaching dentists how to do PRF and doing my one-day courses, etc. And all of a sudden, plastic surgeons wanted to learn about platelet-rich fibrin as well. And so these plastic surgeons would call me up. I was living in Florida, so I'd go to these offices in Miami or Fort Lauderdale, etc., and teach them how to do PRF. And they wanted to do PRF because when they were doing nose jobs or facelifts and doing incisions, they wanted to use platelet-rich fibrin to help with healing, okay, which made sense. And every time that I would go to these offices, I'd look in their offices and everybody would have Vitamedica. I'd go to one plastic surgeon, there's Vitamedica. Go to another one, there's Vitamedica. And I remember asking, I said, what is Vitamedica? And they said, Dr. Ryan, I'm surprised you've never heard of this. They say, we give every one of our patients Vitamedica. I say, why do you guys do that? Well, they say, the majority of the population is deficient in micronutrients. And so some of these micronutrients, such as vitamin C, etc., is very important for healing. And so in these cases, we don't want to do an elective surgery, such as a boob job or a nose job or a facelift, in a patient that's not going to heal optimally because they have low levels of antioxidants, etc. And so they literally force their patients to take this supplement 3 weeks before surgery, 2 weeks after surgery, okay, to make sure that nobody that comes into the surgical room is going to be deficient in any of these antioxidants. And I said, wow, that makes a lot of sense. And so I started looking at this and I said, why don't we use this in dentistry as well? So that's what I started doing. I started using Vitamedica in dentistry because it made a lot of sense to me. Now, the one thing that was discouraged about Vitamedica for me was that it didn't have optimal levels of vitamin D, okay? Because in the plastic surgery field, they're not working so closely with bone, right? They're doing a lot of these soft tissue procedure, boob job, nose jobs, etc. Whereas we're playing in bone all day long. You're placing implants, it's bone, it's bone, it's bone, and you want to make sure that you have enough vitamin D. Standard Vitamedica doesn't have that much vitamin D. So I was taking vitamin D and then I was, using vitamin D and vitamin K to increase their levels. And that was working out quite well. And then I remember talking to the endocrinologist and saying, how can we make this go faster? How can we get the vitamin D levels to go up to speed a little bit faster? And then I learned with the endocrinologist about the cofactors, so boron, manganese, some of the other ones. And of course, I was always getting the recommendations from the endocrinologist as well as the, PhD nutritionist to do this stuff. And I remember, sometimes I was recommending 5 or 6 different supplements for my patients. There was Vitamedica, vitamin D, vitamin K, boron, manganese, this package. And I remember thinking how silly this was, almost like I was a distributor of vitamins or like a distributor of vitamins. And I went back to the company. I said, why don't you guys just make one package like you did for medicine for dentistry? And that's what they've done. And that's called Dentamedica. Okay, so for those that know more about Vitamedica, it's been around for about 20 years. Okay, it's very well known. And it was invented and pioneered as a result of all of these deficiencies in the US population. And I cannot stress this enough, because when you look at this list and you look at the percentage of the population that's actually deficient in a lot of these vitamins, the number one vitamin that population is most deficient in is vitamin D. And that's 70%, and that's the vitamin that's most related to bone. Okay, and that's the one that as a dentist is linked with early implant failure. So it's very critical now to understand this and, as a clinician, to do something about this. So again, Vitamedica, the one disadvantage was that it didn't have high levels of vitamin D, and that's one of the reasons why Dentamedica was created. So they basically took the package of Vitamedica, said, what is this? And then used this with the vitamin D, with the vitamin K, with the boron manganese, all these cofactors to help boost up bone healing. Okay, so that's what that is. Now, of course, it contains all the antioxidants, and these are very important for general health as well. I was very shocked to learn during this time period when I was studying and trying to, get this supplement company to make something that was related to dentistry. I went to a lot of these conferences on nutrition. And I remember going to this one conference, and this was back when I moved back to the United States, 2016, and they showed this graph here. And the graph showed the US life expectancy in 2014, 15, and 16. And one thing you'll notice is that life expectancy was actually going down, okay? And that was the first time that it ever happened. So always life expectancy is always going up, up, up year after year. But in the United States, in 2014 onwards, life expectancy started going down. And this was a result of poor nutrition, right? Cancer and heart disease are the number one killers in North America. And so when you see here, of course it says heart disease and cancer are still by far the top killers. Eat right, exercise, don't smoke. It sounds very simple, but the reality is everybody in North America is overworking. They're not spending enough time in the sun. They're not necessarily eating right. So there's a lot of factors here that play into this. And I was amazed to learn, like I said, you see the life expectancy charts here. This is in the United States from 1980 to 2020. And you see life expectancy is continuously rising. Okay, and we're at around 78, 79 years of age. But all of a sudden in 2014, it starts going downwards instead of upwards, okay? And only in the last year did it start to increase again, okay? So amazingly, this is only happening in the United States. When you look at other countries, for example, here's Switzerland, look at this. Between the same age period, it continued to rise. It never went down, okay? When you look at Italy, it continued to rise. And in the United States, we're around 78 years. Here we're at 83, 82, 83, right? It's continuously to rise. Even in Japan, where life expectancy is some of the highest in the world, it's still rising year after year. Okay, and their life expectancy is almost 10 years more than it is in North America. In North America, we have the best medicine, we have the top schools in the world, the top hospitals, etc. Meanwhile, life expectancy is about 10 years less than in other countries. And the rate is going down every year, whereas in other countries it's going up. And this is mostly attributed to nutrition, okay, and of course, just taking care of overall health. And that's where the antioxidants and other things play a big role in this. I was fortunate as well, because while I was learning a lot about this nutritional stuff, I found the University of Utah developed this little scanner. And the scanner, amazingly, is able to read antioxidants right from your skin. Okay, so it's a little device that it's non-invasive. You can literally apply it, and it shines a light. Okay, and the more antioxidants you have, the more basically the light. So it goes in at one UV light and then comes back at another one. The more antioxidants you have, the more that light bounces back, and then it takes a reading. And the nice thing about this is it's very non-invasive. And in our studies, in our early studies, we were correlating everything to blood work, of course. So we were taking blood work, what are the values? And then we could also take the little finger prick to measure vitamin D. And we can also take this little antioxidant reader, which was very easy to do. And so in these studies, like I said, it was very nice because non-invasively, and very quickly, we can get these readings. Now, in these studies, one of the things that we learned, which was very shocking, was that when we look at smokers, for example, these are our standard antioxidant scores, around 20,000. In smokers, it got reduced, these antioxidant levels, by about half. And this was only smoking 5 cigarettes or more per day. And one of the things that I learned from this study was that smoking is by far the worst thing you can do for your health. I mean, it's amazing how quickly smoking can really lower these levels. And I really think that with smokers, like I said, definitely, every smoker should be supplementing with antioxidants and eating a very antioxidant-rich diet because just the effect of smoking, like I said, is really drastically lowering these numbers. Obesity was another factor. So you see in obesity, it goes from around 20,000 down to 15, 16,000 here at 35% body fat index. And like I said, this was surprising because you could physically look at somebody that was obese, 35% body fat, and you could look at, let's say, a pretty little skinny girl that was 25 years old that was smoking 5 cigarettes per day, and that smoker was a lot worse with respect to antioxidant scores when compared to these obese patients. So like I said, smoking was by far the worst thing for antioxidant scores. Now, when it came to, of course, eating fruits and vegetables, naturally, the more fruits and vegetables you eat, the more your scores are going to go up. But again, how many people in population are eating 6 or more vegetables per day? As a dentist listening to this, maybe you're consuming that much, but your patient population, probably a big majority of your patients are not, right? And so that's where it becomes important to figure out where their levels are at. And more importantly, within 1 month, we could actually supplement these patients, and whether or not they were taking them irregularly, 1 per day or 2 per day, you could within a month really bump their levels up. Okay, so within 1 month, if they took a supplement morning and evening, 2 per day, then within 28 days, they would reach optimum levels, and then you can go into your surgery confident, knowing that these levels would be reduced thereafter. So a lot of investigations have been done, and I'm going to show you guys kind of a study that was done more recently. Of course, when we did these studies, we always use controls. And for me personally, I said, well, how do I know that these supplements that are made in California, that are made under GMP standards at Dentamedica, et cetera, are better than other ones? And so I would just go to the vitamin store, buy some Centrum and vitamin D and do a comparison. And from the studies, like I said, I really learned that there's big differences in the quality of supplements. And I always ask dentists, in my courses, I say, how do you know your supplements are working? At first I ask the question, how many people in this room are taking supplements? And about 70% of doctors will raise their hand and say, yes, I'm taking a multivitamin, I'm taking vitamin D, et cetera. And I say, how do you know it's working? How many of you people or how many doctors have actually tested to make sure that it's working? Have you done blood work? And the majority say, we've never done it. And so that's when we always recommend, for a very cheap amount of money in North America, for $200, you can go get a lab test that'll screen all your panels of all your vitamins, et cetera, and give you an answer. And I highly recommend doing that. And as a dentist, we sometimes do it for our patients just to see where they're at. But as a provider, as a dentist, you can actually get that reading done for free because, the company wants you to be prescribing their, panel of vitamins and minerals. And so you can just say, I'm interested in finding out what my levels are at and providing it for my patients. And you can run a free screening that way there. And I recommend people doing it because a lot of people don't know. A lot of people are taking supplements and a lot of them are not working probably optimized for their own body. Now with Dentamedica, of course, one of the things that we want to do is many studies on it. And we had done a lot of the development. We've been using it a lot in our clinics. And I remember the first independent group to do a study with Dentamedica was at the White Clinic. And so I did this study with Dr. Anna Paz and Miguel Stanley. And the goal of the study was to see whether or not they could take a normal patient population, give them the Dentamedica supplements, and make sure that they can go from before surgery to after supplements, reach the optimum levels, and then go into surgery confident, knowing that they, reach the adequate levels. And in the study, it was interesting because every single patient, we use different finger prick devices. So we used the North American one as well as the European one. We compared both of them to make sure that both were working. All of them were compared to lab work. So every single patient got a lab test done for vitamin D and the 2 finger prick test, as well as the antioxidant readers in these studies. And here's the antioxidant reader. The first thing that I want to share from the study was that the lab vitamin D scores here are shown in blue. The rapid D tester is shown in orange, and the vitamin D is shown in gray here. So these two here are the finger prick, and this is the lab test. And so you see in all the different patients, it's always very, very similar, the scores, okay? And this was perfect because it was a nice, easy way screening, whether or not you use the European device or the North American one. They are very accurate, okay? It takes a little while to get used to using them, so you got to do a couple little tests. But once you're accurate with, your measurement, your 10 microliters, the screening and doing it is very well correlated with blood work. And so then they went through the 6-week protocol. And the way the Denomedica works is that, if you have an implant case to perform, you give the supplements 4 weeks before surgery, they take it for 4 weeks, and then they take it for 2 weeks after. So Denomedica is a 6-week supply of vitamins, morning and evening. You start 4 weeks before surgery, you pump them up, 4 weeks later you can go into surgery, and then because surgery is also a stressful period where their antioxidant scores and vitamin D might decrease after surgery, you supplement them for 2 weeks afterwards. If they do this 6 weeks, okay, you can guarantee that they'll be in the optimal range, okay? It's not a normal supplement. It's not something that you can take every day of your life. It's a super dose, okay? It's made like Vitamedica to be taken before surgery. It's a super dose no matter where you start. If your baselines are low or good, you take a super dose, it pumps these patients up, and then afterwards you're confident to place your implants thereafter. And so here you see the results before surgery in blue and then after surgery. And these are the vitamin D levels. Now remember, anything under 30 is considered deficient. And the one thing that we learned from the study was that in Portugal, which is of course a sunny country, 82% of the population was vitamin D deficient before placing their implants, okay? And think about that. Vitamin D is the highest linked for implant failure. Typically it's, 3 times higher failure rates, and 82% of the population of just random people walking in are deficient, okay? After they took the supplements for the 6-week period, 100% of them, of course, reached the right levels. One thing that I want to make a comment of is that, anything over 100 is considered overdosing, so you don't want to give too much. These are all in the right ranges. But also you don't want to keep these patients on, these supplements long term. You don't want to say, go take Denomedica for a full year. This is really a super dose. It's meant to be taken one time before surgery, and that's it. And then they can go back to the regular regimens, okay, of supplements. This is designed so that you as a clinician, you can confidently go into your surgery saying, I know if this patient took their supplements, they won't be vitamin D deficient, okay? It's 6,000 units per day, 3,000 in the morning, 3,000 in the afternoon with all of the cofactors, and it bumps them up rapidly, okay? And that's why it was designed. With the antioxidant scores, 35% of the population was deficient in antioxidants, and of course, after supplementing, they all reached optimal levels as well. Now, there was one thing that we learned from the study. Of course, like I said, there's been several studies that have been done right now, but 4 weeks before surgery and 2 weeks after surgery is what's recommended. So when you get Denomedica, it's 6 weeks, 4 weeks before, 2 weeks afterwards. One thing that was interesting was that smokers and diabetics, those were the two groups where it was harder to get them to reach optimal levels. And in those patient populations, we typically recommend doing a double dose, okay? That means that instead of doing 6 weeks, we're 4 weeks before, 2 weeks after, we do 12 weeks, we double it. We do 8 weeks before and 4 weeks afterwards. And the simple reason why is because when you're a smoker and you're smoking 15 cigarettes per day, you typically have much lower levels, so you got a longer way to go, number one, and you don't typically absorb these micronutrients as effectively. So like I said, smokers and diabetics, these are the two groups. It's much harder to reach the optimum levels, and in those two groups there, we typically recommend doubling the doses. For everybody else, like I said, it's very standard, 4 weeks before, 2 weeks after, and then you can reach the optimal doses. And this is Dentamedica. Like I said, there's a morning formula and also an evening formula here. And all designed, of course, by endocrinologists. So, of course, it comes with all of the recommended vitamins, minerals for antioxidants, as well as vitamin D. And they also have their proprietary blend to really help boost the levels accordingly. The one interesting thing with dentistry in particular was that with Dentamedica, you can actually, it's the same cost, $98 for the 6-week supply. But in dentistry, as a dentist, you can actually buy it and carry it in your offices. Okay, so you can actually buy them in bulk and get them as cheap as $58. And the advantage of that is that, you can obviously make a little bit of money on the side, but more importantly, you can just offer it to your patients right in-house, okay? And I always say to dentists, if you're going to be placing these $2,000, $3,000 to $10,000, $20,000 implant cases, if it's a full arch case, the last thing you want and the worst thing for your reputation, of course, is always if you're deficient and you have a failure, and that failure was caused by a vitamin D deficiency, that's something that you've just wasted, thousands of dollars and having to redo the case simply because this patient was vitamin D deficient. And the link is there now, right? Showing that it's linked with high implant failure. So I highly recommend, like I said, that patients take the supplements. There's 2 options. Option number 1 is you just say, I'm carrying it in an office and reselling it, or just including it in your cases. And the other one is you can just recommend to your patients to go out and get it on their own. And if they want to, like I said, get it on their own, the company itself has provided these really nice trifolders. Okay, so these trifolders are available, and they're available that you can get them in your office. The company will typically give it to you for free. And the nice thing about these is that, your job as dentists is just to provide the info to your patients, right? So if your patient, for example, is vitamin D deficient, then all you have to do is say, okay, Mrs. Smith, you're vitamin D deficient. We've just done a finger prick test, and this is very highly correlated with implant failure, early implant failure. I highly recommend that you take a supplement. Either I recommend taking Dentamedica directly, or you can go to your local vitamin store and get at least 5,000 units of vitamin D. Take that per day, and then later on you can redo the finger prick to make sure that the patient is in the right range. This little brochure inside, the advantages, it just explains basically, vitamin D deficiency and implant failure. So it's highly recommended that, you take a look at this and just pass these brochures out to your patients just to provide the info. And here's just the brochure. So again, there's a lot of info here. It talks about vitamin D and how important it is for bone and the nearly 300% increase in dental implant failures and all of the benefits here. Okay, so again, like I said, it's a 6-week supply, 4 weeks before, 2 weeks after, and for your smokers and diabetics, just be aware of that. Now, there's been some really great articles that have been written on the topic more recently. One of them has been written by Dr. Scott Froome, and this one here I highly recommend. He talks about vitamin D deficiency, its impact on wound healing and implant failure. And I really like the article because it's a very simple read and it's very easy to digest, as well as it's freely available online. So it's published on Peri-implant Advisory, and you can just go to the article and read it very simply. In the article, you'll see that of the 2,000 implants, he talks about, the vitamin D. So patients with vitamin D deficiency showed an early implant failure rate of 11% versus 2.9% in patients that were normal levels. So there's a big difference there. And he also shows this case. So here, early dental implant failure case, 4 months later. These are the cases that, you look at them and they're going into a lot of bone. We call these slam dunk cases. So you have a lot of bone, implant goes in, there's bleeding, everything's happy. You're expecting this to work out. And then you come back a few months later or even a few weeks later and the implant is a spinner. And you take a radiograph and there's no bone and it looks like the whole area has just been bombed out. And when you see a case like this, I can almost guarantee you 99% of the time it's related to, vitamin deficiency and most likely vitamin D deficiency. Okay, and we highly recommend, if you do have cases like that, just send them for a very simple vitamin D test. And majority of the time, they're going to come back to you and say, doctor, you were absolutely correct. I'm vitamin D deficient. I'm critically deficient. What should I do next? Or the medical doctor will have already recommended to take, X amount of vitamin D. We wrote a nice article as well in Dentistry Today. This was published in April 2020. And I wrote this with 2 colleagues. Dr. Michael Picos and Dr. Mark Bashara. And in the article, it was just titled Vitamin D Deficiency and Early Implant Failure, What Every Clinician Should Know. And the reason why we wrote these articles is simply to provide the info and to make clinicians aware of kind of where we're at in this field here, because of course this is becoming a bigger and bigger topic. We talk about the ability to do the finger prick test because a lot of people are unaware of this, and then also the ability to supplement, what range you should be in, and kind of the studies that show that vitamin D is highly correlated with implant failure rates. In it, we also show a case. This is a perfect case that was done by Dr. Mark Bashara, and I give him a lot of credit for publishing it because, like I said, it's a nice case where the implants are placed, purposely showed a lot of bleeding, and next thing you know, x-rays look good, implants are in the right location. 1 month later, the patient came back and the mouth is completely bombed out. And of course, Dr. Bashara is working in Canada. Case was done in the wintertime, and you take the vitamin D reading and this patient's critically deficient in vitamin D. And that's probably the suspected factor for this failure. And so the goal is to supplement these patients, of course, and then replace the implants thereafter when they reach adequate levels. Better than that, of course, is always to try and supplement them ahead of time to make sure that they reach adequate levels ahead of time. Now, these are the little tests that I was talking about earlier. So if you want to do the micronutrient analysis, you can get this done. One company that does it is SpectraCell, and you can do a full analysis where you measure all the vitamins, all the minerals, etc. This is available in North America, of course. And the nice thing about it is it comes back with all of the deficiencies. And we're actually doing studies right now to figure out what else apart from vitamin D is a linked factor with implant failure. And I can tell you that it's not just vitamin D. There's some other ones that are very common. One of them is vitamin B12. A lot of early failures, like I said, a lot of these patients are vitamin B12 deficient. I don't know if it's correlated or not with implant failure. Of course, there needs to be more research done, but this is kind of where the field is going because we know immune cell health is very, very important for overall wound healing. And so it's more and more research is being done in this space right here. The test that I actually prefer personally is Vibrant America. The reason why is it's just a little bit cheaper. And the second reason is they both measure intracellular as well as extracellular. So you can go on their website, Vibrant America, you can sign up as a provider, and then you can just send your patients to get these testing done, and it measures all of these different vitamins and cofactors, etc., both extracellular levels and intracellulars. It will give you your reading, okay? There's a lot of data. Like I said, for $250 US, I recommend that even as a dentist, myself, I've gotten the test done because you'll be surprised. You'll be deficient in some of these micronutrients, and it'll give you a lot of info related to that. So again, moral of this whole, discussion here and this whole lecture is never forget how important your overall health is, so your immune system, okay? Before you ever place a biomaterial, and as we're going to talk about all the biomaterials in this textbook, never forget how important it is before you place any of these biomaterials or these implants, how important it is that the immune system is properly regulated before these biomaterials go into the body, okay? And so like I said, with Dentamedica, you can get these little brochures. They're very, very helpful. Try and optimize these patients ahead of time. For those that want to learn more about implants in general, and zirconia, titanium, the difference, how immune cell regulates, like I said, Dr. Bossart and myself are two of the people that worked on the immune cell health. This is one course that I can recommend for those that are wanting to learn a little bit more on this topic. So I want to thank everybody for their attention. This concludes the section on immune cell health. Thank you.